911, what's your emergency?
Hello. Hi, we're at Summerfest. I just saw my friend. She's passed out. We cannot wake her up.
Oh, slow down.
Hello? Her shoes, her clothes are missing. Her shirt's ripped. Hello?
Do you know if she took anything? Does she normally use recreational drugs?
No. She never uses drugs. It's so strange. She had half a beer. She was talking to these guys, and we couldn't find her. Why can't we wake her up? We can't wake her up. She's not wearing clothes. Where are her clothes?
So, how many of you have encountered this patient over the course of your careers? I'd be willing to bet that if you work in a center that has concerts, music festivals, colleges or universities that have frosh weeks, you have seen this patient. So I'm here today to tell you about the 3 R's of sexual assault in critical care: recognition, recording, and referral. Sexual assault is a devastatingly common entity, affecting 1 in 3 women worldwide in their lifetime. Generous estimates state that only 1 in 10 of these women will seek help from anyone. But a survey of emergency department waiting rooms found that 1 in 2 women had sexual violence as an item on their past medical history, and some of them disclosed it and some of them didn't. This is more common than breast cancer, than cardiac disease, and stroke. But we aren't trained to look for this in the same way we are these common entities. And I hope to change that for you a little bit today. My own research has shown that my program sees 25% of its patient volumes from things like mass gatherings, music festivals, college and university frosh weeks, national public holidays. And there's certain historical and scene awareness things that come from these types of events that you will encounter in your roles in critical care. So things to keep your radar up for this potentially being a sexual assault patient. Things like drinking minimal amounts and then blacking out, or being very, very unconscious in front of you, being separated from their group, missing or torn clothing, or clothes that are on inside out and backwards, because I can guarantee you a woman that's gone out for a nice night out with her friends did not put her bra on backwards to start that evening. My research also showed that 60% of our patient volume thought that they had been slipped something, an entity known as drug-facilitated sexual assault, or being roofied. This was coined many, many years ago to reflect a drug called Rohypnol, which actually doesn't exist anymore and hasn't been made since the 90s. Today's agents of drug-facilitated sexual assault include sleep aids, ketamine, and GHB. And I realize that saying ketamine on this stage might be a bit of a controversial thing, but this is a totally different way of using it than the standard kind of debate that we get into on Twitter all the time. These drugs are not routinely tested for on hospital toxicological testing. So this is the kind of thing you're going to have to pick up by looking for those clinical toxidromes and someone that seems way, way, way sedated compared to the historical amount of alcohol or drug that you know that they've taken, or their hospital alcohol level that you're receiving back. So there's another historical pointer, is that if the level of sedation doesn't match the level of sedation of the patient, think of something that's been slipped to them.
No 2 sats, normal, and she's avariable at this time. On exam, I see bruising around her wrists and along her inner thighs, abrasions across her upper back, buttocks, and the back of her feet. There is a bunch of dirt and mud caked along her buttocks and vaginal area, as well as in her hair. Cardiorespiratory exam seems normal.
So, as Rosie said, the physical findings sometimes can be subtle, sometimes can be minimal. But there are certain patterns that can be seen with sexual assault. And when we're in our training, we get drilled into our heads the signs of child abuse. And these are not dissimilar to the types of and spectrum of symptoms that we see for people who've been sexually assaulted. So things like bruising in intimate areas, restraint marks around someone's wrists, drag marks across someone's back because maybe they're getting pulled to a more secluded area, particularly at a busy festival. And things like dirt and mud in places that you normally wouldn't find them. It had to get there somehow, and it's worthwhile to ask how it got there. Now, how are you going to record this? Because this is a chart that's most likely going to go to court. And so you want to take your time and make due diligence and care for this kind of documentation. Approximate measurements, locations are good. Body diagrams are best if you have them within your system. A lot of people take photographs of injury as part of their medical records, and that's fine to do as long as it's done in a very sensitive manner and is standard of care in your institution. But just know that those photographs are not admissible in court and cannot be part of the forensic record.
Okay, so your patient in resuscitate 3, so it's a young female who was found down at a concert. So her vitals have been stable throughout her stay here, belly soft, exams benign. She's got a Foley catheter in, there's about 300 cc's of urine there, we haven't emptied it yet. What's left of her personal belongings are in the bag underneath the stretcher, just like a ripped top and a bra. Otherwise, we haven't had a chance to clean her up yet. She's got some dirt still in her hair, on her body, and around her vagina.
Wait, do you think she was raped? Have you done a rape kit? Should I do one?
So what do you guys think? Should you do a rape kit on somebody that's unconscious? Has anyone here done a rape kit in their career as a critical care practitioner? A few hands here and there. Well done. So the sexual assault evidence kit, or the rape kit, is a very intimidating and daunting thing for most clinical providers. It is technical, but the actual performance of the kit is very, very simple. The steps are laid out sequentially and very well written, such that if you needed to do this kit, it's actually quite easy to do. The difficulty rises with consent around doing this kit in the first place, as well as the maintenance of the chain of evidence that goes with a legal document. This evidence kit is often the linchpin that's at the crossroads of the medical and the legal system for this patient, and it often forms most of the evidence that an assault took place. So it is notably daunting for most people. First, with the consent is a little bit of a higher standard than what we're used to in medicine, so an unconscious patient cannot consent to having a forensic examination done. As much as you'd like to try to advance this cause for this person and keep this as an option for them, you cannot do it until she's awake. There is some rules around substitute decision makers, but they vary by jurisdiction and are very, very murky, so it's much easier to get the consent specifically from the patient themselves. The second thing is something called maintenance of chain of evidence. So as soon as the seal on that box is opened, it can never leave your site, which is incredibly difficult to do when you're in a very busy unit and chaos is raining down around you. If you get called away to manage another critically ill patient or even for a question, and that box leaves your site, you might as well take the whole thing and throw it in the garbage, because there's not anything that's going to be admissible in court for that patient. Thankfully, the silver lining in all of this is that people recognize that this is a very, very difficult thing for critical care providers to do, and that we are the entry point for a lot of patients in this circumstance. So specialized sexual assault forensic services were established to help mitigate this need. They are experts in conducting forensic exams and ensuring kind of the downstream care that happens for patients that have been sexually assaulted. Now, if you have one of these at your site, that's the best possible situation. They can come, do concurrent care with you, you handle the medical, they handle the legal, and everything's all great. If you don't have someone at your site, but you can talk to them, that's great. Give them a call. They're experts, and they're a lot easier to consult and talk to than probably a good majority of the consults you do in an average day. And they are a fount of information to help you get this patient to where they need to go. If you don't know what your resources are at your site, or you don't have something, there's a marvelous website here that has a searchable database for worldwide programs. So type in your location, and out pops your closest program. I highly recommend that if you don't know, you give this website a look, and you give them a call when you get back home, because you never want to do this in practice for the very first time. So back to our patient. She's on her stretcher, she's got a Foley bag, she's got some ripped clothes in a bag underneath her stretcher. What do you do? Do you start doing some swabs? What do you do with that Foley care? So medical always comes before forensic, and to maintain that chain of evidence, what you can do is you can pour off a little bit of that urine from the Foley bag into a specimen container, tuck it away with her clothes wherever they're kept in your institution, whether that's under the stretcher or in a cupboard or wherever, And that is considered to maintain legal custody with the patient. So she can have all of her things in the standard way that it's going to have happen, and that it meets the legal standard of care and allows this patient to future go on to a forensic testing if they are wanted. So you don't have to worry about having a big fancy special vault like this to put these patients' belongings in. You also don't need to clean her up right away, because that's washing away the evidence. And if she so chooses that she would like to pursue this legal avenue down the line, then you want her to have that option available to her.
Hi. Can you talk to me? Hello, can you hear me? Can you tell me your name? Hello? Hello? Where am I? What's happening?
So what do you say? How do you respond to someone who's asked what happened in a circumstances where you think somebody has been sexually assaulted at a festival that was supposed to be fun? So having this conversation with the patient is very similar to breaking bad news or any other emotionally charged conversation that we have dozens of times over the course of a day. It should be treated with the same care and respect, that you come to her, find out what she remembers, and that memory might be very fragmented. That happens with trauma, that happens with intoxicants. And then lay out the facts. Facts first, as to what you know. And then you can get into your clinical impression as to what you suspect might be happening for her. And framing it as a clinical impression, make sure that you sidestep any issues of re-victimization for perpetuating some myths of things that she wore or that she had drank something or those kind of things. So if you keep it to a clinical impression, you're usually safe. Having this discussion with someone is going to evoke some sort of response by them. And there is no right way for this patient to respond. It can run the spectrum of human emotion.
Work appears normal. I'm just glad you're finally awake. I understand you might not know what happened to you. Your friends found you unconscious at Summerfest. The paramedics are the ones who actually brought you here to the hospital, where we found a number of bruises and scrapes, but no broken bones or injuries to your head. Your shirt was ripped, and you didn't have any clothes on from the waist down. I have to tell you something difficult. When I see someone who's unconscious with the types of injuries you have and your clothes being lost or ripped, I'm concerned that you may have been drugged and sexually assaulted. We have a number of options that you can take next, and I'm here to help walk you through them.
And that last piece is very, very vital. So allowing somebody to choose their next steps and knowing what those next steps can be makes this a much easier conversation for both you and for your patient. Involving a support team during the time of having this conversation is always great if you can have that. People like social work, that specialized forensic team, even the patient's friend, just that somebody knows that they are there, they're being heard, and they're being cared for. Once you open that can of worms, you have to deal with the worms. You cannot just leave them there. Research has shown that allowing somebody to be heard, to be believed, and to have the option to choose their next medical and forensic care has profound psychological improvement at up to a year after their assault. Things like decreased rates of PTSD, anxiety and depression, decreased rates of substance abuse, and for the financially minded in the crowd, it decreases the almost $2 billion annually that is associated with lost earnings, wages, and potential of these victims. They come to us in all hours of the day, at all days of the week, and we are that lighthouse. We are the port helping lead them back to safety. So, the 3 R's of sexual assault in critical care. Recognition of what this is. This is much more common than all the things that we are trained to look for, and hopefully today you will be trained to look for this. Recording important things because you know that this will likely go to court if the person so chooses that, and referral to a specialized system such that somebody can get the care and humanity that they need. You can be someone's hero, not through a dramatic medical procedure, but by showing up, providing care, and having the humanity that this victim needs at this time. I thank you for your attention.